Well, I want to thank you for the opportunity to come and talk a little bit. Today I'm going to do something that's a little different than what you've heard before. I'm going to talk about one of these infrastructures. We've heard so far about the need for data infrastructures, and so I'm going to tell you about one of them, and one that is easily available to you, either whole bits of it or smaller subcomponents. So the infrastructure that I'm going to talk about is what we're calling the NIMH data repositories. So this is an infrastructure that collects data from about subject level human subjects research, not preclinical, not test tube. We're starting to look at ways to collect data from communities. So that's part of the conversation I'll be interested in having with some of you for the rest of the day. It started with NDAR, the National Database for Autism Research. It's recently expanded to all data supported by NIMH from clinical trials and to data related to the research domain criteria, the RDoC initiative. So these data infrastructures are all set up. Researchers, qualified researchers can access the data. In addition to this, we have developed sort of deep federation with other data repositories that are in these areas so that you can launch a query from the NIMH site and cover all of these other data repositories simultaneously. So this is, roughly speaking, it is infrastructure, right? So we got a big Oracle database. You have several different websites that will let you have access to the database. You can query across that. We have, as I was saying earlier, pretty good linkages to things like dbGaP, to the Rutgers repository about samples, and actually to other autism data repositories that were around before NDAR got started. So just as an overview of NDAR, it's supported by a couple of the institutes at NIMH. It was begun in late 2006. Putting data into a repository is like filling a pool with a garden hose. It takes a while before you have enough data to be interesting. At this point, the pool is pretty full. We have data from over 77,000 subjects. We're holding around 500 terabytes of a variety of different types of data. So, and I said we have good federation. So one question that you might have is, how are the data organized? And there are two principal building blocks. One are data dictionaries. You all know what clinical data dictionaries look like. There are more than 500 instruments that are available. Now, one important feature that happens when you aggregate data, at least based on experience in other communities, is that the scientific community as a whole looks at that number and says, do we really need 500 discrete data dictionaries to cover autism? And the answer is undoubtedly no. And so just the fact of data aggregation allows the community to start to compare various data dictionaries in a real manner and to start to pick winners so that you get to a place where you have a much smaller number of data dictionaries, and that would be a very good thing. NIMH, as you heard in my introduction, is working on other ways to think about data dictionaries, common data elements. But I think the data aggregation approach is really quite useful to ultimately limiting the number of data dictionaries that are out there to the ones that are directly relevant. So here's what things look like, the start of the alphabetical list of all of our data dictionaries. All of this is easily available to you. If you go to ndar.nih.gov, you can click on any of the data dictionaries and download them and do whatever you want with them. One of the nice things, the other one, an additional benefit of aggregating data is that when it comes in, we have a chance to validate that the data are useful, are meaningful. So here are allowed values for just some of the data elements in a particular data dictionary. If someone tries to send us an answer to this question and it's not in the range 0 to 24, we send it back and say, no, that's not quite right. You know, look for where your error is. Researchers, I know from personal experience here, having been in a field that aggregates data, you hate getting told that your data isn't quite right. But after you get over that, you realize, boy, it's nice to have discovered this early rather than late. And you fix it and you make sure that it doesn't happen again, and the quality of the data in your lab is improved, and the quality of data across the field is improved. So I'm quite sure that none of the users of NDAR would admit to liking this feature, but it's a good feature, you know. The other thing that we do is, now that we have a lot of different subjects in this data infrastructure, is that you can just trivially go and do a query, boys in a certain age range, and see what their values of this particular data element look like. So it allows you to compare data that you've collected in your lab with a large sample. It allows you to go into the database and generate preliminary data for NIH grants, and we're seeing this happen more and more in the autism field. And, you know, sort of do meaningful types of experiments. So the other key building blocks, so you can understand how data dictionaries are one important way to sort of describe data from human subjects. The GUID, the Global Unique Identifier, is the other key building block. Now this is a little tricky because we hold this data, we're the federal government, we hold this data. It's really important to us not to hold personally identifiable information in the data repository. All right, so social security numbers are out, you know, all things like that. We just can't have them. The GUID is a way that allows data from multiple different research labs to be aggregated without any of those labs having to share personally identifiable information. This is a useful tool that we're happy to make available to a wide array of research communities. How it works is that there's a piece of software that sits in the research lab. The researcher puts in something like first name, last name, date of birth, place of birth, sex. Those are the variables that go into the NDAR GUID. That information is hashed at the site, and the hashed codes are sent to NIH. If we've seen those hashed codes before, we return to that site the same identifier that we saw the first time, NDAR 12345. If it's new information, a new subject, we return a new unique identifier. So this, in theory, allows data to be aggregated between different labs. You can easily imagine an extension where different research communities could have different identifiers. Instead of NDAR 12345, it could be cardio 12345 or whatever. And as long as there was an honest broker, we could link the data, the subjects between all of those sites. That way we would, all those communities, that way we would avoid creating a de facto social security number, but still allow data from many different research communities to be aggregated. So we're in the process now of finalizing that last step of setting up community-based GUIDs that will interact nicely with the existing GUIDs. And if you have the need to aggregate data like this, I'd be happy to talk to you about your needs later today. Does it work, the GUID? Well, this shows you a query where we asked for all of the data in IAN, which is the Interactive Autism Network, which is a parent self-report sort of data collection. And you see parents don't drop off MRIs, and they also don't drop off genomic data, right? So this clearly shows that some of the data in IAN are from subjects that were seen in research studies in research laboratories. That, I think, you know, is really, really very useful. There's a variety of interesting corollaries here. Those research labs wouldn't necessarily know that the parent self-report data are in NDAR unless they came and looked. So, you know, there's a couple of things that are going on here. I think the one other thing that it shows, which we've been a little surprised at, is how many research subjects are seen in multiple different laboratories. And I think that as a scientific community, we underestimate how frequently we're actually looking at the same subject and sort of assuming that we're drawing from a random sample when in fact we're drawing from a much smaller sample, and that has real possibilities for biasing the sorts of results that we're getting. This GUID technology kind of allows you to get a handle on that. All right, so at this point in NDAR, data's come in, it's got a GUID, it's been defined in a data dictionary. Talk very briefly about the querying systems that we have. The first way we allow queries is from labs. This is the data from Nancy Minchu's lab at Pitt. All of these links are live so that you can go to the data dictionaries, you can go to the NIH description of what Nancy got money to do, you can go to the papers, right? There are reciprocal links between PubMed and NDAR so that if you find one of those papers and there's data associated with a paper, you can come straight to NDAR and get the actual data associated with that publication. That's really what data from papers is all about. We're starting now to assign DOIs, just like we do to papers, to these particular data sets so that this data is more easily discoverable. And finally, there's the query by concept. So this gets back to this question of you have 500 data dictionaries, and a non-expert wants to ask the question, show me all the subjects who have excessive repetitive actions in the database. Well, in order to actually launch that query, you have to know where in the 500 data dictionaries is there a question related to excessive repetitive action. And you have to know that, so here's that list, and you have to know that in this particular CBCL data dictionary, question 66, that if you get an answer of 1 or 2 in that data dictionary, it's equivalent to this giving a 1 to 3, right? That requires not only true expertise, but a whole lot of luck. No matter how skilled a researcher you are, the odds that you actually know the details at this level of all of the potential data dictionaries is very small. So we've worked with true ontologists who have actually done this hard work, although we do a fair amount of data curation ourselves. And the nice thing is that once someone has done this hard work, someone who's interested in this cohort can just launch excessive repetitive action and get 750 subjects and go. If you want to explore the possibility that it should have been 1, 2, and 3 here, you can download this cohort, you can subtly change the query, download the 1, 2, 3 cohort, and see what the difference is, right? So it enables real science, and that's the other thing, of course, that you want to do when you're aggregating data on this scale and at this expense. So, you know, I guess one question about these databases always is, if you build it, do they really come? And like I said, it takes a while for the pool to fill up. But once it's full, people really do come. So we're starting to see papers. We have a lot of people who have access to the data infrastructure. And since I get to see all of the applications that come in autism, I know that there's a lot of data that's being generated in NDAR and being submitted to NIH as part of an application. So just in summary, NDAR is a useful data archive that does a lot of good things, right? And like I said, we're happy to work with almost anyone who has collected data, because we have all of these different data archives now related to mental illness. Happy to work with people on federation, happy to work with people in terms of giving parts of this infrastructure away as we can, and happy to take the data in and make it searchable. So with that, I'll stop. Thank you.